Hello everyone. During this lecture, we will discuss some of the vascular diseases. Vascular diseases are classified into hypertensive vascular diseases, which also includes the arteriolosclerosis, atherosclerosis, aneurysms and dissections, and vasculitis, in addition to vascular tumors. During this lecture, we will discuss the first two topics. So hypertensive vascular diseases are diseases affecting the blood vessels in hypertension. Essential hypertension is defined as a gradual age-associated rise in the blood pressure, which increases as we age. This will increase the risk for various health conditions like stroke, atherosclerotic coronary heart disease, cardiac hypertrophy, heart failure due, and we call it hypertensive heart disease, aortic dissection, multi-infarct dementia, and renal failure. The mechanisms leading to hypertension in the vast majority of cases remains unknown. However, it is an interplay between genetic factors and environmental factors. This will lead to the increase in the blood volume and or the peripheral resistance. As you know, the blood pressure is a function of the cardiac output, which increases with the increase in the blood volume, multiplied by the peripheral resistance. So any increase in the peripheral resistance or in the blood volume will result in increased blood pressure. The cutoffs in diagnosing hypertension in clinical practice requires a sustained diastolic pressure greater than 90 mm Hg or a sustained systolic pressure more than 140. However, in certain patients with other risk factors like in diabetics for example, we lower the threshold. يعني مش ضروري على 140 over 90. We may diagnose hypertension on 130, for example, over 85. So, but this is the general cutoff point to diagnose hypertension. It is associated with a remarkably increased risk for atherosclerosis. The reduction in the blood pressure will reduce the incidence and the clinical consequences, including death for sure, of all forms of hypertension related diseases. So we have to treat hypertension in order to decrease the risk of these consequences. And even we have to treat asymptomatic hypertension to, as we call it, a preventive medicine. In 5% of patients with hypertension, they develop malignant hypertension, which is defined as a rapidly rising blood pressure. If untreated, it will lead to death within 1 to 2 years. The definition of malignant hypertension is a severe hypertension. It's not an acute elevation, it is a severe hypertension over a long period of time. The systolic pressure should be over 200 and the diastolic pressure should be over 120, or any one of these will diagnose a malignant hypertension. Patients with malignant hypertension should be treated promptly, and frequently these patients have renal failure and retinal bleeding, retinal hemorrhages, with or without papilledema. So any patient with malignant hypertension should be treated in order to prevent death. The pathogenesis of hypertension. Hypertension is divided into two forms according to pathogenesis. In 95% of cases, it is called primary or idiopathic, in which the underlying cause is not known. And most of the time, it's a factor of aging, in addition to some risk factors. Some of them are genetics. The 5% of cases of hypertension are secondary to an identifiable underlying condition, and those patients mostly are younger age group, and there is an associated health condition like a primary renal disease, renal artery stenosis, renal vascular hypertension, in which there is a problem in the kidney and the vasculature and the renin-angiotensin production, and adrenal disorders, among others. The mechanisms of essential hypertension. The essential hypertension is the primary hypertension in which no identifiable specific cause is found. However, it's an interplay, as I said, between the genetic factors and the environmental factors. The main mechanisms include reduced renin sodium excretion, which occurs as a result of aging. The kidney will retain the sodium, which will reabsorb water with it, and this will increase the blood volume, increasing the blood pressure. Also, the vascular resistance increases also as a result of chronic vasoconstriction, so it will elevate the blood pressure. Genetic factors are important, but there is no single gene responsible for hypertension. It is a result of genetic polymorphisms in the genes involved in regulation of renin-angiotensin and angiotensinogen, and in the regulation of lipid metabolism. So there are multiple genes, and this is evident in the familial clustering of hypertension in certain families. In addition, and it stands very importantly, the environmental factors like stress, obesity, smoking, physical inactivity, and high levels of salt consumption. It is highly linked, the high levels of salt consumption, with the appearance of hypertension. Hypertension affects the blood vessels in various forms, like it accelerates atherogenesis and the development of atherosclerosis, and also it causes degenerative changes in the walls of the large and medium-sized blood vessels, arteries, leading to aortic dissection and cerebrovascular bleeding. Also, it affects the small blood vessels, which we call the arterioles, leading to hyaline arteriolosclerosis and hyperplastic arteriolosclerosis. So we will discuss first the hyaline and hyperplastic arteriolosclerosis, then we will go into the atherosclerosis, and we will discuss aortic dissection in a separate lecture. The hyaline arteriolosclerosis, it occurs with benign hypertension, not in malignant hypertension. Um, in the kidneys, the hyaline arteriolosclerosis leads to nephrosclerosis and the scarring of the glomeruli, which will lead with time into the renal failure associated with hypertension. Now, hyaline arteriolosclerosis is not specific for hypertension because we can see it in elderly, normotensive patients. Also, it's common in diabetic patients. It is characterized microscopically by the appearance of a homogeneous pink hyaline material in the arteriolar wall, with a loss of the underlying structural details associated with luminal narrowing, وبالتالي decrease the blood supply to the affected organs. Why this homogeneous hyaline material is deposited in the wall of the blood vessel is due to the leakage of plasma components across the injured endothelial cells into the blood vessel wall. So it is characterized, as you can see here, by a pink hyaline material on the wall of the small arteriole. This will lead to narrowing of the lumen and decrease blood supply. The hyperplastic arteriolosclerosis, on the contrary, is typical for severe hypertension or malignant hypertension. In malignant hypertension, also it can be associated with a fibrinoid deposition and necrosis of the blood vessel wall, which we call it necrotizing arteriolitis, particularly prominent in the kidney. The vessels in hyperplastic arteriolosclerosis assume an onion skin-like pattern under the microscope, with concentric laminated thickening of the arteriolar wall, which also leads to luminal narrowing and decreased blood supply. As you can see here to the right, lower part of the picture, there is a concentric narrowing, which we call it onion skin-like مثل قشرة البصل, leading to a very small lumen end of the blood vessel. The other hypertension-associated health condition is the atherosclerosis. Atherosclerosis is characterized by intimal lesions. We call them atheromas or atherosclerotic plaques. These will impinge on the vascular lumen, leading to stenosis first. This could also rupture and causes a superimposed vascular thrombosis, leading to sudden occlusion of a blood vessel, or sometimes they can weaken the underlying media because of the compression of the underlying media by these atherosclerotic plaques and decrease blood supply of the media of the blood vessel. This will lead to aneurysmal dilatation of the blood vessels. So atherosclerosis is associated first by stenosis, second by superimposed thrombosis and acute block of blood supply, and third by the development of aneurysms. It underlies the pathogenesis of coronary vascular disease, cerebral vascular disease, and peripheral vascular diseases affecting the lower extremities. Atheromatous plaques are defined as raised lesions. Usually they are yellow in color and they are composed of a core of lipid material, mostly cholesterol and cholesterol esters with necrotic debris. These cores are covered by a fibrous cap. So as you can see here, the yellow area represents the extracellular lipid, which is composed of cholesterol and cholesterol esters. This is the necrotic center. Some of the lipid is present in the macrophages, within the macrophages, as you can see here as yellow droplets. So it's considered here intracellular. As you can see also the core, the lipid core contains migrating smooth muscle cells. These elongated cells are smooth muscle cells. And it is covered by a fibrous cap composed of smooth muscle cells, collagen, and sometimes lymphocytes with a new vascularization. The underlying media of the blood vessel with time will undergo atrophy and weakening, وبالتالي ممكن يصير في عنا weakness وبالتالي ممكن يصير في عنا aneurysmal dilatation. There are constitutional risk factors for atherosclerosis, and they are the genetic factors, specifically the familial hypercholesterolemia and multifactorial traits, like, for example, hypertension and diabetes. Age is an important risk factor because the incidence of myocardial infarction or stroke increases with aging. For example, MI increases fivefold between the age of 40 to 60, and the death rates also increase as well. Regarding gender, premenopausal women are protected against atherosclerosis. However, after menopause, the incidence increases and sometimes it can exceed that in men. Sometimes this is attributed to the effect of estrogen as a protective factor in premenopausal women, but this idea has some problems because the administration of hormone replacement therapy in postmenopausal ladies is not associated with a decreased risk of vascular accidents. بالعكس ممكن إنه يزيد الريسك of vascular accidents. So these three factors, the genetic factors, the age, and the gender, are non-modifiable constitutional risk factors for atherosclerosis. We have another risk factors which are modifiable major risk factors like hyperlipidemia, specifically the hypercholesterolemia, the hypertension, the cigarette smoking, and the diabetes mellitus. So hypertension is associated and smoking are associated with an injury to the vessel wall, accelerating the process of atherosclerosis. Diabetes also increases the risk of all atherosclerosis associated complications like ischemic heart disease, stroke, جلطة دماغية, and gangrene of the lower limbs. Specifically, the hyperlipidemia, or more specifically, the hypercholesterolemia, The cholesterol is found in two forms, the low density lipoprotein cholesterol, which is considered the bad cholesterol. This will increase the risk for atherosclerosis. However, the other part, which is the high density lipoprotein cholesterol, that is considered the good cholesterol, it is associated with reduced risk for atherosclerosis. So the aim is always to decrease the level of LDL and elevate the level of HDL. The high dietary intake of cholesterol unsaturated fats زي اللي موجودة بالegg yolks والanimal fat and butter in excessive amounts certainly raises the plasma cholesterol levels. The omega-3, for example, which is abundant in fish oils, is beneficial and it can raise the HDL levels. Exercise raises the high density lipoprotein levels, whereas the obesity and smoking will lower them. So, all of these factors will affect the level of cholesterol and the risk for atherosclerosis. Morphology, when I say morphology, it's either macroscopic or microscopic. The appearance of atherosclerosis requires a series of morphologic changes that occurs in the walls of the blood vessels, starting by fatty streaks, which is defined as lipid-filled foamy macrophages in the wall of the in the blood vessel near the intima, near the endothelial cells, which is not associated with a raised lesions. It's minimally raised, or sometimes it's difficult to see. They do not cause any significant flow disturbances, and they start as early as in the early childhood, as early as the infancy period. However, it's not all fatty streaks will develop into atherosclerotic plaques. However, some of these fatty streaks will fuse together and enlarge to form the atherosclerotic plaques, which are associated with the intimal thickening, the intima of the blood vessel, and accumulation of lipids, and the yellow raised lesions, which we discussed earlier in the lecture, covered by fibrous caps. These lesions are patchy. They do not involve the whole circumference of the blood vessel. Usually they come at an eccentric location in the blood vessel. With time, they will enlarge and impede the blood flow and causes the narrowing of the lumen of the blood vessel. In descending order of frequency or severity, the most commonly affected blood vessel by atherosclerosis is in the infrarenal abdominal aorta. The coronary arteries comes then, the popliteal arteries of the lower limbs, then the internal carotid arteries, which increases the risk for stroke and cerebral accidents, and the vessels of the circle of Willis at the base of the brain. For unknown reasons, the upper extremity blood vessels are spared from atherosclerosis, as are the mesenteric arteries, the renal arteries, except at their openings, at their ostia, where they emerge from the aorta. So as you can see here, these are the openings of the blood vessels from the aorta, and this aorta is opened longitudinally, and you can see the small yellow lines are called the fatty streaks, which are not associated with any elevated lesion. As you can see here under the microscope, they are only macrophages filled with lipid, and they can occur in childhood. As the person or the patient ages, atherosclerotic plaques appear more commonly, and they are larger and elevated yellowish lesions, as you can see in picture A. In picture B, these atherosclerotic lesions are associated with the complications like ulceration or superimposed thrombosis, giving them this brown color. Atherosclerotic plaques are susceptible to acute, clinically important changes. So the atherosclerotic plaque can undergo rupture or ulceration or erosion, and this will expose the underlying highly thrombogenic substances like the lipid core, for example, leading to superimposed thrombus formation. When the thrombus forms, it can totally occlude the blood vessel, resulting in an acute syndrome like myocardial infarction if we are talking about the coronary arteries, for example. The second acute complication is a hemorrhage into the plaque, leading to formation of hematoma within the plaque. This will increase the size of the plaque and it can occlude the blood vessel. Third, these atherosclerotic plaque can develop into emboli. Some part of these atherosclerotic plaques will detach and is carried in the circulation and it acts as an embolus, occluding a subsequent blood vessel. We call this atheroembolism. And finally, they can lead to aneurysmal dilatation of the blood vessel and rupture of the blood vessel as an acute complication. This is due to the weakness in the underlying media due to atrophy by the enlarging plaques and due to the decreased blood supply. So as you can see here, we have a preclinical phase which starts as early as in childhood in the form of fatty streaks, and these fatty streaks are yellow in color, like usually they are not associated with any health complications because they will not occlude or narrow the blood vessel. As they enlarge, they will develop into fibrofatty plaques. These fibrofatty plaques are usually eccentric with a lipid core impinging on the blood vessel lumen, leading to luminal narrowing. With advancing size, it will lead to a critical narrowing. Now, the clinical phase is accompanied by the complications which we talked about, like rupture or erosion of the plaque with a superimposed thrombus formation, hemorrhage into the plaque leading to hematoma, aneurysmal dilatation and rupture of the blood vessel, and sometimes the progressive growth of the plaque will lead to critical stenosis, leading to a severe narrowing of the blood vessel, decreasing the blood supply to the affected organ. As you can see here, this is a histologic section of the artery in which there is a rupture of the hematoma, uh, as you can see at the arrow side. And this rupture can be accompanied by a superimposed thrombus formation, which can totally occlude the blood vessel. The clinical pathologic consequences of atherosclerosis. Now, the large elastic arteries like the aorta, the carotid, and the iliac arteries, in addition to the large and medium-sized muscular arteries like the coronary arteries, the renal arteries, the popliteal arteries, هم the vessels that are most commonly involved by atherosclerosis. So the consequences will be myocardial infarction or heart attack if it is in the coronaries, cerebral infarction or stroke if it is in the cerebral blood vessels or the carotids, and aortic aneurysm if it is in the aorta, peripheral vascular disease resulting in gangrene of extremities if it is in the iliac blood vessels or in the popliteal arteries. These are called the clinical syndromes associated with atherosclerosis. Now, whenever we have an atherosclerotic plaque and it enlarges, it will lead to an atherosclerotic stenosis. This stenosis leads to impingement or decrease in the blood flow, either by the acute plaque changes, which we already discussed, like a superimposed thrombus, for example, or atheroembolism, for example, and or a gradually increasing size of this atherosclerotic plaque leading to critical stenosis, which is defined as 70% occlusion of the blood vessel. This will lead to chronic occlusion, which will limit the blood flow to the affected organs. If we are talking about the heart, the patient will develop angina, الذبحة الصدرية, which will precede the development of myocardial infarction. It's a chronic problem. Bowel ischemia, ischemic encephalopathy, also it can precede the development of a stroke, and intermittent claudication, which is pain in the limbs upon walking due to the decreased blood supply of the lower limbs due to this stenosis. Thank you for listening.